Well, good morning, everybody. My name is Jens Chapman. I appreciate all of you being here. Thank you, Dr. Drazen. So my name is Jens Chapman, and I appreciate all of you coming here. It's a particularly important Grand Rounds because it's the first Grand Rounds after a very significantly negative media exposure. And by you being here and supporting educational events, it supports the notion that what we're doing here is extraordinary and directed at improving patient care. And that's the primary goal of why we are here. It's also very important that we learn about the topic at hand. It's a distinct pleasure to have Dr. Daryl Fourney here. He's a long-term friend, and it's great to have him here as our John Jane visiting professor. And he's from Saskatchewan, and we share, again, one of our faculty members' background is from the same beautiful university in Saskatoon, Saskatchewan. He's our John Jane visiting professor, and we actually shared a dinner together in Sun Valley, I think about 6 years ago. I think the oldest was 2 years. We sat at the same table. And I know for a fact that the late Dr. Jane would be so delighted to have Daryl here. He's made a landmark impact with his research. He's a surgeon's, mind you, so he is the one who's created the SIN score, which all of our fellows take such great delight in reciting, but he's made a substantial difference with that. His spinal cord injury studies, his myelopathy, geriatric odontoid fractures, and today he's talking about something that is pretty remarkable, and that's at the foundation of his accomplishments. He's a very quiet, very efficient connector of people and concepts. He managed to create, over 10 years ago now, I think, a integrated low back pain care map for a whole province with the goal of improving care and, again, being resource savvy. So this is something that is, in terms of the content, very important for all of us here. And it's also very important for us to see how he has accomplished this with a unique talent of diplomacy and articulation. And this is the same thing that led to the success of the globally accepted SIN score, which is now used literally in 5 continents, for which he brought spinal oncologists from 5 continents together. You can see his bio, but importantly, he is well recognized politically. He is the past chair of the Canadian Spine Society. He's the program chair of the AANS and CNS meetings in the past, and he trained with the famous Ziago Kazlan, one of our good friends and spinal oncologists. So Daryl, it's a great pleasure to have you here and educate us on how you did what you did and what the content is. So welcome.
Thank you. It's a great pleasure and a great honor to be asked to come. This is a fantastic place you guys have here, and I am thrilled to be part of it today for you. So I'm going to talk about this pathway that we developed in our humble province. Let me see how we can advance there. I don't have any commercial disclosures related to this work, just some research grants that are paid to my institution, not to me. I'm going to talk about the objectives of what are the components of a modern clinical pathway. What is a pathway? What is that anyway? And why would you want something like that? I want to talk about how you can make these kind of changes on a systems level and some of the problems with implementation of clinical care pathways and methods to overcome it, at least from our experience. And I want to talk about some of our outcomes and how it's affected MRI and surgery utilization in our province. So first thing, if you're going to know about the Saskatchewan spine pathway, is you have to know where Saskatchewan is. We say it's easy to draw, hard to spell. It's a Cree word. It means a river with a fast-flowing current. But it's a geopolitical region, a province in Saskatchewan, right in the heartland, right in the middle. And you know, President Trump is concerned about the military spending of your allies, but I can assure you that we have we have a very proficient army and high-tech weaponry. We are an innovative people. Here you can see 6-foot scrap of lumber, $1.27, 8 screws, 72 cents, but the aerodynamic advantage is priceless. And this picture was actually taken in Saskatchewan. That is a Saskatchewan license plate. So the reason we started, and everybody has a different reason for deciding to make changes in their system, in their healthcare system. In ours, it was because of wait times, and it was in particular, the wait time to see the spine surgeon. Not so much the wait time for surgery, but the wait time to see the spine surgeon. And this is a study out of Eastern Canada, but it shows that this is just a neurosurgeon who just collected prospectively the reasons why patients came to see him after he saw them for back pain. And really only just under 20% were actual surgical candidates that were offered a surgery. Everybody else kind of came to see him for various other reasons. Chronic pain, not amenable to surgery. They're improved. They're really not really wanting an operation, but they just want more information, that kind of thing. Second opinion, maybe mechanical pain that's more appropriate for mechanical treatments or other things, and really only 20% for surgery. We did this same kind of work in our own province, and depending on the individual, everybody has a little bit different surgical yield from their clinics, a little bit different referral patterns to individual surgeons, but that number can vary between 10 and 25%. So there's been some interest because of this wait time problem to see the surgeon and all these patients that come to see you that really probably aren't appropriate for surgery. So in order to study the appropriateness of a surgical referral, you have to have a definition for what is an appropriate referral to a spine surgeon for back pain. And this was a stab at this from a group out of Edmonton. They said that an appropriate referral was one that stated that leg pain was the chief complaint, or those that described physical exam evidence of a neurological deficit, and the imaging report was positive for nerve root compression. And when they applied that definition, they found that about 26% of their referrals were appropriate. But I don't think this is an appropriate definition. For one thing, can a patient not just have back pain? Is that not a good reason to see a surgeon? If they've really done everything else, if there's good reason to operate on that patient, absolutely it could be. They don't need to have a neurological deficit or leg dominant pain. There's lots of patients that we operate on quite reasonably and within guidelines and consistent with back dominant pain. The other thing that's problematic with this definition is that there's an inappropriate focus on the imaging study itself. It's true that most spine surgeons require an imaging study to be completed before they'll consider a referral, but the problem is that if you sort of triage your patients just based on imaging, the problem with imaging is because we require the imaging in order to see the patients, in some ways it kind of sets things up. It sort of says you need to have that imaging study. And we know that up to 90% of imaging findings on lumbar spine MRI are inconsequential. They're false positives. So these abnormalities that the patient or the PCP or referral doctor see on the imaging study when they get that report may actually just simply increase their demand to seek a surgical fix. They see these wear and tear changes in the spine, these disc bulges and things, and if they weren't sure if they were going to see the spine surgeon before, well, now they're certain that they need to see the spine surgeon after seeing that imaging study. So it doesn't really help with triage. And we know there's tons of information about overutilization of MRI. There's no question that there's overutilization of lumbar spine MRI. In different jurisdictions, it's going to be different. In our province, lumbar spine MRI accounts for about 1/3 of total MR utilization. This was a study in JAMA published a couple of years ago that looked at, based on appropriateness guidelines, what percentage of lumbar spine MRIs are appropriate. The good thing out of this study was that the neurosurgeons did the best in ordering the most appropriate scans, and it goes down a lot as you look at family physicians. But this is who's going to be ordering these studies because they want to potentially see the spine surgeon. So what you can conclude from the practice before, if you're concerned about what our concern was for our pathway, which was wait time number one, that the current system wasn't working very well for us. And that we needed an effective strategy to promote appropriate referrals seen earlier by the surgeon, but at the same time, evidence-based, non-surgical care for the rest, for the majority of patients. So how do you accomplish that? So we know that if you adhere to evidence-based guidelines for low back pain, and there's tons of these guidelines, and they're very consistent with each other. They're well-published guidelines, 40, 50 of these guidelines. We reviewed them a few years ago in a focus issue in spine on low back pain that Jens was the lead on. We know at that time there were at least 40 of them that we had looked at. And there is evidence that keeping within those guidelines produces superior outcomes and may improve efficiencies. A clinical pathway is a method to take those guidelines and put them into action, to change the landscape of care, to change the practice patterns by changing the landscape of how you do business. So you can have all the guidelines in the world, but if you don't change your practice patterns, you've got this thing called a translation gap between guidelines and clinical practice. So as part of that focus issue, and this is back in the early days of our pathway back in 2011, we started with a systematic review of what clinical pathways were out there for lower back pain. And at the same time, that was when we had introduced the spine pathway. So it's been, it's actually the 5-year anniversary of our full implementation this year now. So evidence for what is a clinical pathway? Evidence for these pathways is derived by guidelines, but a pathway is distinguished by a few things. It coordinates multidisciplinary care. It facilitates communication among care providers. There could be a specialized electronic communication means between those providers. There could be a classification system that they use. It includes resources for ongoing quality improvement. So you don't just implement an algorithm and say, okay, let's go with it. There needs to be a constant check based on what you determine are the benchmarks for success in your pathway. You need to be constantly looking at those in a feed-forward fashion all the time and making sure that your pathway is doing what you want it to do. And then there's a central focus, of course, with everything nowadays, of course, on the patient experience. It's patient-centered, it's not physician-centered. So it's multiple interventions into a healthcare system that's based on best evidence, best practice, patient focus, coordinates communication, and has this ongoing quality improvement. And the goal is to reduce variability. And hopefully by reducing variability, we can address rising costs while improving quality. That's what a clinical pathway is. So back in 2007, our Ministry of Health came to us and said, look, we've got this problem with wait time 1 for spine in our province. You guys put it together. See if you can figure out a way to make this better. And we already had care pathways in the province for hip and knee surgery. So they said, well, if we got a successful pathway for hip and knee, I mean, if your pain is coming from your hip or your knee, we've got a pathway. Why can't, if it's from your spine, why can't we do that? So we had to get the players together, which was not just the surgeons. The lead was coming from orthopedics and neurosurgery, but we also had primary care physicians, representatives from that group. We had the chiropractors at the table, the Chiropractors Association for our province, the pain clinics, the health region officials. It was a 3-year process of starting with sort of systematic reviews and what we felt were the guidelines and best practice that we were going to follow, and then how we were going to reshape our system and how we could manage that. And then an external review, and finally we came up with the pathway. Why did it take so long? It took 3 years because it's never been done before. Lots of HMOs and different health groups have a pathway or an algorithm for their spine patients in their group, but it had never been done before for a geopolitical region where you have, you might have this idea that Canada, well, it's a single payer system, it's one system. Spine, it's still the Wild West. There's multiple different providers, private people, people that are on salary, more affiliated with the university. There's a whole host of different providers. And we knew that if we were going to make a change in back pain, it didn't just have to be at surgery. It really has to start in the first contact with a patient, right at the primary care level. What we do in surgery is a tiny part of the back pain, puzzle. There's a whole bunch that happens before they ever get to us, and we know that to affect change in the system, we had to start from the ground up. So our development was over 3 years. As I said, we started with some live courses in 2010, and then our online course went live in 2011. And our clinics opened in later in that year. So we had the 5-year anniversary of full implementation last year. So that's why a pathway, at least for us. Everybody's reasons for pathways can be different. I talked to one of your guys here last night from India, and he's interested in kind of improving the spine care in India, and their focus on what they would want would be different in theirs. But I think essentially anything that you're going to implement like this, making change in a healthcare region, has to have three components. It's going to be education, and the education wasn't just for the providers, it was for the patient. It's going to have a patient care aspect, which is our triage clinics, and then it has to have this ongoing quality improvement and research component. So we started, like I said, with live courses, and just with the live courses, never mind the online training. In our province, there's just about 1,200 primary care physicians, and we've since we started just with the live course, we've trained over 500 of the primary care physicians. We've trained virtually all the nurse practitioners in the province. All of the chiropractors have taken our live course. Imagine every single chiropractor in the province has taken it. Why would they want to take this course? I'll explain to you, because if you're going to build a system, you have to build in incentives in it, and I'll explain why that is. And all of the physiotherapists that do spine have taken the course. And then there's other physicians too, in rheumatology, in neurology, in rehabilitation medicine, in other areas that have had a keen interest in it and taken part as well. And our spine pathway course can be found at www.spinepathwaysk.ca. Since January of 2016, it's free to enroll. It's not as good as our live course, but it's pretty good. There's videos, and there's sort of an assessment that you take at the end. So we're talking about what is this pathway now. So it's education. Central into the pathway is a classification system, and any way that you're going to approach the back pain thing, you've got to have a way of categorizing it, because back and leg pain problems, obviously it's a heterogeneous condition. There's multiple things going on. But we wanted to have a system where we could use the same type of language, whether you were a chiropractor or a nurse practitioner or a family physician or a surgeon, so that we all knew what we were talking about. Because what the chiropractor might call a lumbago or what someone calls sciatica isn't what someone else calls sciatica. You'd be surprised how variable these terms are. So we we didn't come up with this. This is derived from, I don't know if you're aware of the CBI system promoted by Hamilton Hall, Canadian Back Institute. We have no affiliation with them. There's no disclosure here that there's no. They've since changed their classification, actually, that they use in their private clinics. But we have used and modified that into this pattern system. So what this is a way. What we've done is we've broken down back and leg pain into essentially 4 syndromes. So the reason it needs to be a syndrome is because you don't have the etiology yet. This is before imaging. This is what the primary care doctor can do in their clinic based on symptoms and signs. There are basically 4 syndromes, 2 back dominant syndromes and 2 leg dominant syndromes. And what we teach, I'm sorry, oh goodness. I'm going to need a napkin there or something. What we teach in the pathway course is a very specific way to take history and do physical examination to determine this pattern diagnosis. Thank you very much. Sorry about that. That's perfect. We're not going to go into what this is, but suffice it to say, we have a classification system that's central to it, and it's been tested for inter-observer reliability between physios and OT and physicians. It's actually been, and this is Dr. Hall's work out of the CBI clinics, not from us. Thank you, Jens. Thank you, appreciate that. This was a paper in Spine Journal back in 2009, where using that approach, that classification system approach, has been proven for validity this is in a non-surgical setting. They basically compared the outcome in terms of back pain in physiotherapy clinics where they were using the pattern classification system versus a conventional system. This is the nuts and bolts of what the pathway is. So you can see that there's 3 groups. There's the primary care group up here. So a patient comes in with lower back or leg pain and comes to a primary care practitioner. And this could be a physiotherapist, this could be a chiropractor, this could be a nurse practitioner, this could be a family physician. They determine, based on history and physical examination, if there's any red flags. They make a pattern diagnosis. If there's red flags, then they're not appropriate for the pathway. You call the spine surgeon on call. That's an emergency referral. But, try to get my arrow going here again. So if there's no red flags, you make a pattern diagnosis based on the symptoms and signs as we discussed. And the patient information you get then derives from that pattern diagnosis. So we don't just have a handout that you give the patient about self-care for back pain. We have a handout that you give the patient for self-care for that pain pattern. Okay, so it's specific to that pain pattern. And we have a treatment algorithm that is specific to that pain pattern. Each of these syndromes of pain has a different timeline for when you would expect success to happen based on the primary care management of that condition. If those timelines are not met, if the patient is not improving, what do? Do you phone the spine surgeon? Do you phone the neurosurgeon? Do you phone the radiologist and try to get an MRI? No. You refer that patient to the spine pathway. If they're not meeting the benchmarks for improvement on their own with primary care, then they can go on to the spine pathway clinic. So we're not trying to reinvent all of the primary care that's happening everywhere, not trying to just create a center of excellence for the care. That still happens in all these communities over this large area that we cover. But if the patient is not meeting these benchmarks, then they can be referred to the pathway clinic. Why would the primary care doctor want to refer them to the pathway clinic rather than call the surgeon or the radiologist? Because we've set it up so that the wait time for the pathway clinic is tight. It's one of the quality features that we monitor. The patient, it's a maximum of 3 weeks to get into the pathway clinic. They do the same thing there. They're going to look for red flags. They're going to reassess. Maybe the pattern was wrong. Maybe the diagnosis was wrong. Maybe the patient wasn't doing the treatment. Maybe they just needed more advice. If the patient makes improvements, then they can have 1 to 3 follow-ups with the spine pathway clinic. It's not to replace the care at the primary care level. It's to help triage. If they're improving, then they go back to primary care. If they're not improving, then they can refer the patient on to MRI and surgery. So again, when the patient goes through the pathway, the benchmarks are monitored closely and set. So why would the surgeons have basically agreed to see the patients from the spine pathway clinic earlier, and the imaging is set up that those patients have already been screened and are appropriate. So those patients are set earlier for MRI and surgeon assessment. So the surgeon still gets his MRI done, but the checks and balances have happened in the system all the way through. So you can see from this, the spine pathway isn't really about surgery. It's all about what happens before the surgeon is involved. But it has to have involvement from the surgeons, because we direct what we want the care providers in the spine pathway clinic to look for. We've trained them. We've told them what we want them to look for in terms of who's an appropriate surgical referral. So how did we get compliance? Basically, the maximum wait for the triage clinic is 3 weeks. We set priority appointments for patients that have been screened through the pathway for both MRI and surgical referral. And because we're requiring our primary care providers to do extra work, they're not just giving their conventional diagnosis, they're giving a pattern diagnosis. They're not just doing conventional treatment, they're doing our algorithm treatment. So we've actually changed the fee code system in the province. So the fee codes are a little bit different in Canada because each is set provincially instead of a federal, instead of a nationwide coding system. It's a little bit different in each province. So in our province, we have a special fee code for spine pathway utilization. And they get CME for taking the course, but that's not been done. The interesting thing is the utilization of the surcharge fee it's not been the biggest. We thought that would be a big thing to promote compliance, but it looks like based on the utilization of that fee code, what has really helped promote compliance is just getting that education out there, explaining to the primary care community why we need this system, why it's better, and just providing better quality care for the patients. And I can show you as we go through the these patients are happier through the system because they're getting better information. And they're getting consistent information. They're not getting told something different. When they go to see the primary care doctor and when they go to the pathway clinic, you don't have a difference in opinion necessarily of what there is, because we're using a system that is reliable so that we don't have that surprises. So for the next part of this, I'm just going to break from the presentation, and I want to just show you our resources online so you can see where to find them if you're interested. So you could just go to Google, and the good news is you don't have to know how to type Saskatchewan. You can just type spine pathway. Just spine pathway. And everything that comes up is us. So this is the first one up here. This is the patient page. And you see that because it says patient there. So this is just the information for the patient about the pathway clinics. This Back Surgery, a guide for patients and their coaches, is a 44-page PDF of what happens before, during, and after your surgery. And this was, work that we combined with all of the spine surgeons in the province and our primary care physicians. This is the Maintaining a Healthy Back General Information PDF. And then these are the back exercises for each of the pain patterns. This down here, spinal stenosis, should I have surgery? Herniated disc, should I have surgery? These are shared decision-making algorithms. It's like do you remember those books like Choose Your Own Adventure? It's basically what it is. The patient can sit down with this and, should I have surgery for my spinal stenosis? The patient can enter this information, and it goes through with them step by step, the decision-making around it, the pros and cons, and the recent evidence for that. So this is available to everybody. None of this is copyrighted or anything. If you decide to use any of these handouts or anything, the only thing is we suggest that you do not modify them and include the Ministry of Health. So this is the provider webpage. So for this one, this is the link to the online course, which I said is free to enroll now. And then this is the referral form. It's a one-pager checkbox to the Spine Pathway Clinic. So what this is also is the baseline collection data for the primary care doctor. So he can just use this. It can be incorporated into the EMR of the physician. And if the patient's not meeting their algorithms, it converts into the referral form to the pathway clinic. And then these are the primary care provider algorithms. So this is the algorithm for pattern 2, for example, for them to follow. This down here is the link to our chronic pain care program if the patient ends up pattern 5, which is chronic pain disorder. But we're just focusing on the mechanical patterns for today. So that's a little segue there. Let's go back to the presentation. That part's always more effective if you actually see me click the links. So as I said, we have this quality assurance step. All the patients going through the pathway clinic get a VAS back and leg, they get an ODI, and they get a quality of life study. SF236 was too big and cumbersome for us, so we're using the EQ5D. So our first publication came out in 2014 in Neurosurgery, and it was, in this one, it was basically, I had a big pile of referrals that I was never going to get to, and I just said, look, you guys triage this, and I just sent them to the Spine Pathway Clinic. And it was a small study, but basically what we found from that was that we had Group A. So this was the Spine Pathway Clinic said, look, these patients do not need to see the surgeon. Group B, these ones can see the surgeon. And basically when we worked it out, at the end, the total number of patients offered surgery from the whole group worked out to be 12%, which was very similar to our historic number of 15%. If you look at how the what kind of patients the spine pathway selected, they tended to have greater disability scores for mobility and poor EQ. And they had higher ODIs, so poor function on ODI. And they were much more leg dominant than back dominant. So not to say that back dominant patients can't be a good surgical referral. It's just that isn't usually most of the surgical referrals to a spine surgeon for degenerative conditions. And we looked at imaging utilization in the entire, and this was the total MRI imaging utilization, including the whole year prior to the initial referral. The MRI utilization in the spine pathway group was only 25%, and in the group that was ultimately referred to the surgeon was 92% before they came to see the surgeon. So the spine pathway reduced surgical referrals by 71% and reduced MRI utilization by over 50%. It didn't miss any red flags, and patients triaged to surgery had more leg-dominant conditions, greater disability, and poorer mobility scores. So then fast forward about a year later, this is another paper that we published. This was comparing two groups. So comparing, and I should say, this isn't Big Brother coming in. We didn't take anything away. We added the spine pathway, but the conventional means for referral to the surgeon and everything are still there. So as I sit there as a surgeon, I have a great study because then I can compare my conventional referrals to my spine pathway referrals, and that's what this study was. This wasn't here, triage it all and just send me what you think is surgical. This was comparing conventional referrals to spine pathway referrals once we were kind of up to more full implementation. In this study, we found no difference in ODI or the overall EQ5D, but they still had a higher proportion of leg dominant pain and poorer scores for mobility, and they were significantly more likely to be surgical candidates. And because of the way that the system was set up, also the spine pathway patients had significant shorter wait times to see me and shorter wait times to have an MRI. And now we've just stopped, we just finished enrollment of our big prospective study. We don't have all the data crunched yet, but we're seeing from that work a big difference in the patient satisfaction with the regular referrals versus the conventional referrals. And I spend a lot less time having to deprogram patients that come through conventional referrals with this idea that they have to have surgery and that they're here to see me for surgery, and getting it back to the discussion about what's really going on here. What have you tried? What have you done? There's so much less of that happens now in the spine pathway referrals. And look at the number down here that were marked very unsatisfied or really didn't receive any care for their back prior to receiving me. So the conventional referral, it was 13%. Spine pathway was 0%. So this was not the reason that we developed the pathway, but what's been interesting, because it's been 5 years, is we've been able to see what some of the effects have been on surgical utilization at the age of 45. So that suggests that we're doing fusions in younger people more than other people. So we wanted to look at this variation piece, and one thing to understand is the province is broken up into 13 different health regions, but all the surgery is done in 2 centers. We basically have, Saskatoon's the one in the north, Regina's the one in the south. So basically what we have here is a petri dish. Everybody in the province pretty much goes to these 2 centers for spine surgery. And these 2 centers are connected through this pathway. So we could do a really interesting regional variation study and look at population-based numbers. So that's harder to do when you've got different systems and a sort of a patchwork quilt of people going all kinds of different places. So in this study, we decided to look at the extent of low back surgery variance in the province and determine possible causes. So we tied provincial billing records for new spine surgery to consultations within the previous 18 months. And I'm not going to say which center, but there's the 2 centers. So we're going to call them TC1, Tertiary Center 1, and Tertiary Center 2. We looked at wait times for surgery, and utilization of the spine pathway clinics was also analyzed. So the first thing that came out in this analysis is if you tie where the patients came from to where they had surgery, there was almost no migration. So if you were from the health region, and I simplified it from 13 health regions to 11, because the 2 in the north have very small patient population numbers. But if you look at where the patients are coming from, if you're in the geographic area for Tertiary Center 1, you generally go and have 94% of the health regions served by Tertiary Center 1, they get their surgery at Tertiary Center 1. And for Tertiary Center 2, 86% of procedures performed in Tertiary Center 2 are from those 6 to 11 health regions. So the migration wouldn't account for any variation. But here's what we found. The blue tab is the Saskatchewan rate, and you can see that the Tertiary Center 2 is doing numbers of spine surgery that are very similar to the national numbers, but Tertiary Center 1's numbers were just so much higher that it brought the Saskatchewan number up. And these differences were not accounted for by patient migration. In fact, Tertiary Center 2 does more of Tertiary Center 1's patients than the other way around. A lot of the complex stuff from Tertiary Center, from the areas served by Tertiary Center 1 actually go to Tertiary Center 2, because Tertiary Center 2 is the is a little bit more specialized. So this was interesting. So why is that? What is going on here? And because we could tie it back to the patient, and because we had population-based numbers, we could actually get some answers for this. So if you look at, so the first thing that jumps out at you is you say, well, it must be then that the surgeons at Tertiary Center 1, they just must be operating on a lot, everybody. They just must just, everybody that comes in with back pain, they're just operating on them. Well, it's not the case. If actually, if you look at the referrals, if you're in Tertiary Center 1, your yield, that is the number of patients that you take to surgery from your clinic, is 14%, which is totally reasonable. At Tertiary Center 2, it's a little bit lower. It's 12%. And because we had such big numbers, it's statistically significantly different. But I don't think that's clinically significantly different, 14% versus 12% take. But the difference was, look at the denominator. Look at the number of patients with a new spine surgery consultation. They were significantly different. So if you actually tie it back to, remember I said we had the populations for these different health regions, and we knew the migration patterns from these health regions. So you could actually tie population-based numbers to this. So what made the difference was the referral rate to the center. So the rate of new spine surgeon referrals completed was double. So Tertiary Center 1, which had smaller numbers that they take from, the province's population is about 1.1 million. They have an area they serve which is about 480,000, but they were seeing many more referrals than we were seeing in Tertiary Center 2. So they had just set up a practice pattern where the primary care physicians tended to send patients to a surgeon earlier. So the most striking variance was not the surgical yield. It wasn't really what the surgeons were deciding to take, but the rate of referral to the surgeons for back pain. So the information that you can take home from this for the spine pathway is that potentially you could achieve a difference with this with variation. You could potentially reduce it through more regionally consistent utilization of the spine pathway. So if you take your referrals through the spine pathway rather than through the conventional means, you might be able to change this variation. And in fact, that's what we've seen over time. So this was initially Tertiary Center 2 had pretty quick uptake with the spine pathway. It took Tertiary Center 1 just a while to catch up. This study was done a few years ago. And now those numbers are more consistent. So where it is right now, the spine pathway sees provincially about, and we have about 1 million people in the province, about 176 new patients per month. And on average, about 24 of those patients are ultimately referred to the surgeon, so about 13%. And as a result, you can see the wait time for spine surgery in Saskatchewan has dropped, but the total number of surgeries has not changed. So in summary, the unique features of our pathway is it's inclusive for all types of mechanical type back pain. It's not for tumors. It's not for red flags. This is for spinal stenosis, disc herniation, back dominant pain for various reasons as well. It's based on a classification system that has been proven to be reliable and validated, at least in the non-surgical area. It's patient-focused. Mostly what we've changed is at the primary care level. And what I've said time and time again is that the big piece for variation in surgery, a lot of it is happening before people ever come to us. Everybody looks at what surgery is doing because what we've seen is doing is very expensive, but it's also valid. So I think if you're going to make big changes in back care and back pain, it has to happen before the surgeon. We've implemented this in the healthcare system of a geopolitically defined region, not just one healthcare system. And it includes all the defining features of the modern clinical care pathway. So this spine pathway has rubbed off, our experience has rubbed off on Australia, on New Zealand, and different countries. The most recent has been Belgium. This is Belgium. They want to develop a spine pathway for Belgium. And what I liked about this was the web page online for tenders to do the research for the government of Belgium to decide what spine pathway they should look at. The Belgian government wanted them to look at the different spine pathways worldwide, and so they could get more information. But basically, they said that they have to look at least 5 countries maximum, but they have to include the Saskatchewan province of Canada. So we're, the Belgians like us. That's it. That's what we've done. So.
Congratulations on a great topic and discussing it so well, and also showing us how teamwork and just gentle persistence can really change things. We should have a lot of questions, but let me just go ahead. Canada being Canada,